right now, and then I'm going to share my screen with you, and we will take off right where we left last time, which should be right here. Let me just change one thing. Okay, so the last time we got a little bit of a dent into the big chart. That's the compilation of all of the radiopharmaceuticals used in the United States today. And hopefully it's a good sign for me that we're talking about Alzheimer's disease, and I actually remembered where to start this time. So hopefully that will be helpful. The first drug I wanted to mention is called florbetapir. It's F18 labeled, so of course it's a positron emitter, and we will be doing a PET scan on it. And what we're looking for is plaques that are called beta amyloid. That's the material that localizes in the brain, in unfortunate cases, causes tangles and memory loss, and eventually involves the death of the patient prematurely. And it's very interesting that the package insert, I copied part of this out of it. Look what the package insert says. A positive scan, and that drug is called Amyvid. Positive scan does not establish a diagnosis of Alzheimer's disease or any other cognitive disorder. In other words, let's jump ahead to here. This, let me fix something over here. Okay, so this slide is giving you some idea of how it works. This drug binds to these plaques. We collect the photons coming out, the annihilation photons form a coherent image, and then a negative scan basically tells us that it's not very likely to be Alzheimer's, and a positive scan basically tells us that it is very likely to be Alzheimer's, but even the manufacturer says a physician should not be saying this patient has Alzheimer's disease based just on this scan alone and not with other medical evidence. Now, let me just go back a slide or two here just to mention that we collect a 10-minute image, but post-injection, we wait typically 30 to 45 minutes before we begin the imaging. And also the radiation dose is pretty reasonable. A 10 millicurie dose is a whole body dose of only 700 milligrams. That is nothing to get too excited about at all. Okay, next, and this is a source of board questions, and I'm going to show you what some of them might be. Next, we want to talk about bone imaging agents. There are 4 of them that are commercially available today, and here they are. F18 sodium fluoride. Most of us have probably never seen a sodium fluoride bone scan before, even though it is the best bone agent that there is. It clears the blood faster than any of these phosphonates do, and the tumor to background ratio is higher than any of them. So you might be thinking, if this is the best agent, why don't we use it? And it's a matter of reimbursement. Medicare, which usually sets the standard for reimbursement, says you can use sodium fluoride if you want to, but we're just going to pay you for a bone scan. You prefer sodium fluoride over MDP, that's fine, go right ahead. But think about this, an MDP bone scan charges about $1,000. A PET bone scan is about $5,000. The reimbursement is the same for both of them. And so you'll take a big hit by doing a fluoride bone scan. So unless there's a really compelling reason to do so, we would choose one of these other drugs. Besides, these are all very good agents. In most cases, it doesn't matter which one you use, they're all going to be satisfactory. In my department, we use methylene diphosphonate. I know that here in Chicago at Northwestern Memorial, they use hydroxymethylene diphosphonate, and pyrophosphate was the very first bone agent that was approved in 1972, and it's really a good bone agent. It's just not quite as good as the other 2. So you can see these 2 are underlined as an agent of choice. And if you get an exam question where you have to determine how many millicuries would you inject for a bone scan. I think last time we talked about why we had to give so much. Typical injected dose is 20 to 25. The package insert says 15 to 25, but most people aim on the high end of that range. We aim for 20 to 25 millicuries. So here are the official names. This is methylene diphosphonate, shown on the bottom here. This is hydroxymethylene diphosphonate. And this is pyrophosphate. Now, integrated into this whole section for radiopharmaceuticals would be the mechanisms of localization. I used to give that as a separate freestanding part, not anymore. I've incorporated them all together, and I think it's a better way to teach it. So with sodium fluoride, this is an occasional exam question. What is the mechanism called? It's called exchange diffusion. If you look at the chemistry here on the bottom, here's what's happening. The fluoride ion diffuses into the bone tissue, and then this fluoride and this hydroxide on hydroxyapatite literally trade places. So hydroxyapatite becomes fluoroapatite. Now, you may have never heard of fluoroapatite before, but every time you brush your teeth, you're using fluoroapatite. It's simply monofluorophosphate. It's all that it is. So this is the only example I know of that is called exchange diffusion. Again, the fluoride is diffusing in and exchanging places with the hydroxide. For the phosphates, it's a totally different mechanism. The old name was physicochemical adsorption, but not anymore. Today, they refer to it as chemisorption. And here's what's happening. The phosphate or phosphonate groups that are on these molecules can bind almost instantaneously once they get into the bone, instantaneously and irreversibly, and actually very avidly. It's a very tight bond to the bone agent. And so that's how these work. The phosphate or phosphonate is adsorbed onto the surface of this hydroxyapatite structure. Our bones are comprised primarily of hydroxyapatite. The chemical formula for this is simply calcium phosphate, and that's what our bones are made out of, tricalcium phosphate. And so that's an example of chemisorption. Here are our three radiopharmaceuticals labeled with technetium. I mentioned already that MDP and HDP are the two most commonly used. And typically in adults, we inject the patient and we say to the patient, go away, come back in 3 hours and empty your bladder, and then we're going to start the imaging. In children, we can actually start probably closer to 2.5 hours. Perfectly okay to wait to 3 if you would choose to. Now, this question was on a board exam. It was actually on a doctor's exam, not a technologist's exam. But I would be surprised if somebody in this group does not get this correct. The question is, which one of these is methylene diphosphonate? Now, if you take a look, every phosphorus atom on this whole chart has 2 hydroxides and a double bonded oxygen. The only difference must be what's in that central backbone structure. Here it's POP. Here it is PCH2P. And here it is PCHOHP. So which one do you think is methylene diphosphonate? Top left, top right, or bottom? Anybody?
Top right.
Good, top right. This one has a hydroxide here on the carbon, so this would be hydroxymethylene diphosphonate. This is PCH2P, that's a methylene diphosphonate, and this is pyrophosphate. So they're all very similar. In fact, MDP and HDP differ by this one oxygen atom right here. Other than that, they're identical. So they're all very, very similar structurally from a chemical standpoint. And there's the correct answer for all of those. I'm not an expert at reading films, but there are a couple of here that I want to show you because This one in particular is a scan with a name. What's wrong with this patient? What's your diagnosis? Is this normal or abnormal?
Abnormal.
Is it abnormal or grossly abnormal?
Grossly.
Grossly. This is a patient who is in very, very bad shape. We all know what a normal bone scan looks like. All of this black area all over the spine and the pelvis and the knee joints down here up in the skull, it's all metastatic disease. And you can barely see the kidneys. Yes, I can see them, but barely. So a scan with very extensive metastatic disease and very poor visualization of the kidneys is a scan that has a name. What is it?
Super scan?
Good. That is a super scan. And that's a common exam question. How about this patient? What's wrong with this guy? You can see here.
Paget's.
Yes?
Yes.
I'm
They're
sorry.
saying maybe they were saying maybe Paget's.
Good. This is a perfect example of Paget's disease. There are certain bone structures that are so intensely radioactive compared to everything else that's just characteristic of Paget's disease. The rest of the bone structure here, you almost can't even see it. Even the ribs are barely visible by comparison. What about these two spots in the spine, though? Do you think that's Paget's or perhaps degenerative changes in the spine in an older patient? And that's exactly. Yes, this is degenerative changes. This is not Paget's. One of the clues is it's just so perfectly symmetrical. What's this hot spot over here?
Infiltrate.
That's the injection site. Very common to see it. We almost always see it regardless of what we're injecting. This is a good exam question. What is the typical distribution of technetium bone agents, MDP, HDP? That is, what's the percent of the injected dose that goes to bone? And what is the percent of the injected dose that clears through the kidneys? Is it 30-70, 70-30, 10-90, 50-50? What's a typical distribution in an adult?
50-50.
Good. That is correct. Roughly half of it goes to bones and half of it goes through the kidneys. Now, think about the following. Half of it goes to the bones. That means half of it doesn't. Point number one. Point number two, we're waiting half of a half-life for the patient to come back to be imaged. So we're imaging 70% of 50%. So at 3 hours down the road, only 30% of the injected dose is still in the bone tissue. That's one of the reasons we have to give so very much. Now, I just asked you this question in adults, same question, but what do you think is that ratio in children? It's no longer 50-50. What do you think it is? Higher or lower?
Would it be higher in children?
Sure, it'll be higher. Children's bone metabolic rates are much higher than ours as adults. And so the ratio is going to go up. And the answer here is roughly 75 or 80% in the bones and 20 to 25% that clear through the kidneys. And that's why in almost all cases, children's bone scans are spectacular compared to scans of us adults. They have a higher bone to background ratio, and we expect them to have better scans. And also in children, they have typically good functioning kidneys. And so we're not very likely to see soft tissue uptake unless there is a renal malfunction of some kind. Okay, here are some potential exam questions. Let's consider those 4 bone agents that we've already talked about. Which one of these has the most rapid blood clearance and the highest tumor to bone ratio?
F18 sodium phosphate.
Perfect. So I gave you that a few minutes ago. Perfect. F18, that's why it's the best bone agent. Which one of these localizes by exchange diffusion?
F18.
Good. The fluoride exchanges with the hydroxide. Pyrophosphate is what was used, we're going back now 25 or 30 years, many years ago to detect externally detect acute MIs. would technetium MDP and technetium HDP also work? Now, what's happening here is, let me see if I don't have the slide, I'll show it to you later. But what's happening here is in an acute infarction, tissue becomes necrotic and there is deposition of hydroxyapatite crystals. Yes, technetium pyrophosphate binds to hydroxyapatite, but so do all of these. So we would expect that, yes, all of these would work for external detection. It's kind of a moot point because I don't think any of you have ever seen an acute MI scan before. We don't do them because cardiologists don't order them. And why don't they? They have so many other ways of determining, did an infarct take place? Is it fresh or old? How big is it? Where is it located? They're pretty good at that. And they don't really need us, and that's why we don't do this scan. So true or false, on a molecular basis, the mechanism of localization of pyrophosphate in bone tissue and pyrophosphate in acute MIs is the same. And the answer is true. Why is it localizing in our bone tissue? It's hydroxyapatite. Why is it localizing in an acute MI? Hydroxyapatite. On a molecular basis, it's the same. Remember, our bones have hundreds of grams of hydroxyapatite. In an infarct, there might be hundreds of micrograms or maybe 1 or 2 milligrams, not much. This is right off of an old exam. Consider a bone scan and an x-ray, just a regular radiograph. For detection of metastatic disease, which is going to be more sensitive but less specific?
Bone scan.
Good. A bone scan will find disease earlier by months or even in some cases years than an x-ray, but it's less specific. That hot spot might not be a tumor, it might be something else. True or false? Pyrophosphate localizes in an acute MI. We know it does that. But how about ischemic myocardium and scar tissue? So your question says true or false? It localizes in acute MIs and ischemia, but not scar tissue. True or false? All right, let's take this one piece at a time. Does it localize in scar tissue? The answer is no. And so what we really want to find out is, what about ischemia? Do we have deposition of hydroxyapatite in ischemia? The answer is no, we don't, because ischemia is reversible. People who have ischemic heart disease at certain times can revert back to normal. We see ischemia on heart patients on stress rest tests all the time, but that would never be positive on a pyrophosphate scan. So this is false only because this does not localize in ischemia. What is the typical injected dose of technetium labeled bone agents? And we
15 to 25.
Good. And what would it be for the F18 scan? I don't think I covered that, but that'll be about 15 millicuries typically, about 15. True or false? MDP is valuable for performing symptomammography. We're looking for breast cancer with a radioactive drug. True or false? So which drug is used for symptomammography? And so this is,
maybe?
yes, good. This is false because the drug that we choose is Cardiolite, which is technetium labeled Sestamibi. That's a generic drug name. What is this mechanism of localization called for all of the technetium bone agents? What's the name of the mechanism?
Chemoabsorption.
Good, chemisorption, right. And that's a surface binding. It binds to the surface of the bone, but not to the interior of it. Okay, bone marrow imaging, you are highly unlikely to get a question on this. If you do, however, the drug of choice today is sulfur colloid, and we typically would give 10 millicuries. For a liver spleen scan, we would only give 5 to 8. But remember that in a liver and spleen scan, 85% goes to the liver and 10% to the spleen, and only 5% goes to marrow. So we need a bigger dose. So we would typically use more like 10 millicuries. Again, doubtful you would get that as a board question. And we're going to skip the second question here. But what percent of sulfur colloid localizes in the marrow? And I just mentioned that that's going to be 5%. And this is a preformed colloid, unlike the indium, which forms a colloid in the body. Palliation of pain. We're going to have an extensive discussion of this in the radionuclide therapy lecture, which will be probably 2 weeks from today. Don't hold me to that, but I think so. And these are the drugs that are commercially available today. No one is going to use P32 today. We just don't use it. It gets the patient in trouble quicker than any of the others. Yes, it works fine, but it's not the most beneficial for the patient. Up until about 3 years ago, strontium chloride was the agent of choice for millicuries. Today, and this should be underlined, today almost everyone is using radium chloride. You might know the drug by the name of Xofigo, Xofigo. And this is a typo here. If you have your notes, this, I don't know, it looks like the font changed. This should be 150 microcuries per kilogram. 150 millicuries per kilogram would kill any human and most large animals. This is 150 microcuries per kilogram. Sorry about that. I'll have to make that correction. Samarium 153 EDTMP. This is a bone agent. This is ethylene diamine tetramethylene phosphonate, similar to MDP. And all of these work. This one, the radium chloride, the one you're probably most likely to be asked about today, requires doses, multiple doses spread out over several months. And we'll talk more about that in the therapy lecture. Here are a couple of exam questions. If we consider strontium chloride, P32 phosphate, radium chloride, and samarium EDTMP, they all work. Which of the 4 drugs is our calcium analogs? Now, here's a clue. Calcium is a divalent cation. It means it's a Ca with a 2+ charge on it. So which of those might have a 2+ charge on them? So that's kind of a tough question, and unless you're a chemistry expert, but strontium chloride is Sr2+, and it's right beneath calcium in the periodic table. And radium would be right beneath all of those in the periodic table, except it falls in the actinide series, and it's in one of those 2 rows at the bottom of the table. So these 2, strontium chloride and radium chloride, are calcium analogs. We wish we had a good calcium isotope for therapy, but unfortunately we don't. These other 2 are phosphates. This is obviously a phosphate. This is a methylene phosphonate. They're both phosphates. So of the 4, these 2 are calcium analogs, and which are phosphate analogs, and that of course would be phosphate and EDTMP. Which of the 4 drugs has the shortest physical half-life and therefore has the earliest onset of relief? And unless you know the half-life, you wouldn't know that. The answer to that would be samarium, that has about a 25-day half-life. Which of them has the longest half-life and therefore the longest duration of pain relief? And that would be strontium, which has a 50-day half-life. And so we have never used samarium before, ever. Yes, it works faster, but it doesn't last as long. And we would rather use one that lasts longer. So we've always used strontium. Today, we're only using radium chloride. Brain lesion imaging. You might not know this, but back in 1980s and earlier, nuclear medicine was the champ at brain tumor imaging. There was no such thing as CT before, let's say, 1985. There was no such thing as MR or ultrasound or any of the advanced modalities. We only had glucoheptanate brain scans. And these 3 drugs here all work pretty well. What they did was they actually leaked through the membranes and it's called a blood-brain barrier. They leaked through defects in the blood-brain barrier and localized by some unknown mechanism in malignant tumors. And we were the only ones that could find those tumors with one of these scans. We gave 25 millicuries because if we were lucky, the tumor uptake was 2 to 5%. It was not very high. So we were the big winners in that. And as soon as CT became popular, we went from doing 5 or 10 of these scans a day to 5 or 10 a week to 5 or 10 a month to 5 or 10 a year to 0 over just a period of a couple of years. Now today, there has been a resurgence in brain imaging because we are using F18FDG, 15 millicuries, and this is done post-surgically to answer the question, did the surgeon get it all? Surgeons might say, I think I got it all, but I'm not sure. And very often they order the FDG PET scan, and very often we will find things that the surgeon left behind. He's not a bad surgeon, it's just some tissue looks normal, they leave it behind, but it actually has disease in it. And so this is a very sensitive way of evaluating post-surgical patients to see if there is residual disease. So today, very, very uncommon to do a brain lesion scan. I can't imagine anyone doing it today. How about this? True or false? Thallium chloride, the same thallium that we use for cardiac imaging under unusual circumstances, has the ability to identify the very aggressive malignant brain tumors. We're talking about gliomas, glioblastomas, astrocytomas, the really bad ones. True or false? Thallium is useful for that. And the answer is true. Right here, I didn't mention it before, but it's in the chart. Thallium chloride, 5 millicuries. No one really knows why it localizes in those brain tumors, but some people use this routinely to look for brain tumors. FDG is valuable for post-surgical evaluation. We already said that's true. I did not discuss this yet, but does anyone know the mechanism of localization of FDG in tumors in general? What's that mechanism called?
Metabolic trapping.
Excellent. That's called metabolic trapping. Tumors think that FDG is a sugar and they take it up, but it's not really a sugar, it's a sugar analog. And so they can take it up, but they can't metabolize it. By definition, a sugar is metabolizable. This is not. So it's simply trapped in the tumor. It can't get out, can't be metabolized. And it's our good fortune that it's taken up in the tumors much more avidly than in normal tissue. The percent uptake of glucoheptanate in brain tumors, you're not going to get that question, but the answer is very low, probably 2 or 3%. Brain perfusion imaging, this drug here was the first one introduced, Ceretec, and here's the real drug name for it, hexamethylpropylenamine oxime, and Neurolite, ECD, is ethyl cystinate dimer. And both of these go right through the blood-brain barrier and localize in the brain. And it's a very good reflection of brain perfusion at the moment of injection. It's like taking a photograph. You captured a moment in time. And that's what this does also. It's telling you what's the perfusion at the moment that you did the injection. This is a very good way to evaluate for a stroke or a bleed of some kind in the brain. It's positive almost right away, whereas a CT scan might take a 24 hours, maybe less, but maybe 24 hours to become positive. So here are a couple of questions. True or false? This is regarding these two brain agents. They both work the same way. Both have the ability to penetrate an intact blood-brain barrier. That is true. Nominal uptake in the brain is 20%. That is, of course, false. We're lucky if it's 5%. These drugs can detect disruptions in brain blood flow earlier than CT. That is true. And they can help to detect an epileptic focus if you inject them during the ictal phase. That means while the epilepsy seizure is going on. That's the ictal phase. And this is true. If you are fortunate enough to inject this during a seizure, it's pretty easy to find where that seizure is located. The source of the seizure is located. Also, FDG works for that. What percent of the injected dose of HMPAO goes to the brain? Excuse me. The answer is about 5%. And here's a graph showing you the dynamics. Corrected for decay, the uptake in the brain peaks at about 2 or 3 minutes, and then it's a plateau for hours. So we don't have to image right away, and we typically wait 30 minutes to let the background clear out a little bit before we would do one of these brain scans. So again, a flat line, it's got just basically a long biological half-life. Breast cancer, I asked you this question before. Cestamib is what we use. They came up with this name, Miraluma. I don't know why, because it's exactly the same drug product as Cestamib. We just order a Cestamib dose. And typically, while the package insert says 15 to 25 millicuries, we're going to typically give 25. And why is that? These breast tumors do pick up this drug most of the time, but we're lucky if the uptake is 2%, pretty low. That's why we have to give so very much. True or false? Cestamib would be good as a screening method for breast cancer. We know that mammography is what's typically used, but how about this? Would it be a good screening method? Yes or no?
No.
No. Good. For 2 reasons. Number one, the radiation dose from Cestamib is much higher than for mammography. I'm not saying it's high. It's a very reasonable dose, but it's a lot higher than mammography. And for women who have scans year after year after year, the cumulative radiation dose might add up to be something that's potentially dangerous. Also, mammography costs maybe $250, $300. Cestamib breast scan is probably between $1,000 and $2,000, so it's cost prohibitive. If every high-risk woman in the United States had a Cestamib breast scan every year, it would bankrupt the healthcare system. It's just way too expensive. True or false? The Cestamib uptake in the heart, when we do a myocardial perfusion scan, is equivalent to the uptake in the breast cancer. True or false? It's actually true. They are both about 1.5 to 2%. Think about this. The nuclear cardiology industry is based on a scan with an uptake of 2%. If we're lucky, it's that much. What does that mean? That 98% of the drug is in the wrong place. So Cestamib is not good for screening. And yes, the uptake of in both heart and breast cancer would be around 1 or 2%. Now, there are 2 categories of cardiovascular drugs. The first one I want to discuss is the blood pool imaging agents that we have. And the second is the agents that localize in the heart muscle, but actually clear the blood pool fairly rapidly. So what we have for cardiovascular blood pool today is technetium red cells. That will always be your agent of choice. Chromium is not even available anymore. And even if it were, we don't use it for imaging. We would only use it for red cell mass studies and things of that sort, where we gave 50 to 80 microcuries. So the agent of choice, autologous label red cells, and the amount that we're giving is 25 millicuries. Why so much? What's the blood volume in even a diastolic heart? It's 120 milliliters out of 5 liters. You're only looking at about 2% of the blood pool at any moment in time. That's why we need so very much. Now, we're going to talk about a very important mechanism here, and you're going to see it appearing and reappearing a bunch of times. And I want to define it for you because some books don't have a real clear definition. Compartmental localization means that we are administering a radiopharmaceutical that is localizing in a fluid space. Now, note what fluid means. A fluid is defined as a liquid or a gas, not just a liquid or a gas. And that will come into play when we talk about ventilation agents. So we're placing it in a fluid space and we're imaging that fluid space. Now, let's take as an example MDP. we're injecting it into somebody's vein, fluid space. But are we imaging that fluid space? We are not. That would not be compartmental localization. But here, we're putting it in the blood pool. We're imaging the blood pool. Perfect example of compartmental localization. And so we're using technetium autologous RBCs, and RBCs have a typical diameter very close to the diameter of a capillary, around 7 or 8 micrometers in diameter. Media distribution, of course, is to the blood pool. Ultimately, some of the technetium will break off from the red cells and will clear through the kidneys. So we always expect to see kidneys if we image long enough. And here's something interesting. The biological half-life of technetium red cells, if you have done a good job of labeling them with either a kit or with centrifugation techniques, we usually use UltraTag and give 20 or 25 millicuries. And here, the biological half-life is 15 to 25 hours. What does that mean? We're doing a GI bleeding study. We can actually go out up to 24 hours on one single injection. The proviso for that is that we have done a great job of labeling the red cells. We're going to talk later about red cell labeling techniques. Here are some excellent exam questions. Most of these came off old exams. When we label red cells to either technetium or chromium, but we're more concerned about technetium, what molecule are we labeling? Would you like some choices? Ferritin, transferrin, hemoglobin, or I can't think of another bad answer. So how about those three? What are we labeling? Transferrin?
The hemoglobin?
Hemoglobin, yes?
Hemoglobin?
Hemoglobin, great. And since you got that one right, I'm going to stick you with the answer for the next question. What portion of that molecule does the technetium bind to? The central heme portion or the peripheral globin portion? Okay, that's kind of a tough question, really, if you don't know the molecular structure. But the heme portion has an iron in the middle, and we can't displace that iron under physiological conditions, so it actually binds to the globin. Now, believe it or not, here's your real exam question. Which of the globin chains is involved in the labeling process? Alpha, beta, gamma, or delta? There are no delta chains, and the correct answer here is beta. So what are we really labeling? We are labeling the beta globin chains on the globin in the hemoglobin molecule. So let's keep in mind, the molecule is hemoglobin, the portion of the molecule is the globin chain, and the specific chain would be beta. I know that sounds like a crazy board question, but it's very common. What is a reducing agent that we use to prepare red cells for labeling with technetium? You've all done it before. What's that reducing agent? How do we prepare a MUGA patient? What do we do? What's that first injection that we do?
PYP?
So what we're going to be giving is actually tin. It's called stannocyan or tin-2. Here's the designation here. And we're going to inject stannous pyrophosphate. You probably have heard of it as cold PYP, cold meaning not radioactive. So we reduce with stannocyan. The stannocyan binds to the red cells, and then we come along and inject technetium 20 minutes later, and the technetium is reduced by the stannocyan, and it binds to those beta globin chains on the globin in the hemoglobin. And how much stannocyan does it take to label or to prepare the blood pool of an adult? Might surprise you, 1 milligram in 5 liters of blood is enough reducing agent to tin the blood of someone up to 225 pounds. 1 milligram. We don't need any of these large quantities. And tin, by the way, tin is considered a heavy metal. And yet, in the long history of labeling red cells, which goes back literally 50 years, almost 50 years, no one has ever been harmed by statocyan. So 1 milligram will do the job. Okay, this is the second category here. These are the drugs that actually clear the blood pool, localize in the myocardial muscle itself. And so the first two are potassium analogs. Why don't we use potassium? It would be great. It's the physiological tracer. We don't use it because there's no good potassium isotope. So these are the two choices for potassium analogs: thallium and rubidium. In fact, rubidium is right beneath potassium in the periodic table, right beneath it. Thallium is way over on the right side of the chart, but both of these are what we refer to as monovalent cations. They have a +1 charge, and they are taken up in the heart by the same mechanism as potassium. I'm going to skip the MIBG. That's just used for very specialized studies, very rarely done. These are the commonly used ones: cestamide, which is cardiolite, and tetraphosmine, which is MyoView. We use tetraphosmine. Many other hospitals use cestamide. It really doesn't make a difference. They're equally good. And I've got a large amount here because some people will give, let's say, 15 millicuries for the first dose, and then 35 millicuries for the second dose. And that's so large because it will swamp the activity that's residual from the first dose when we do the resting study. So these are the drugs. Potassium analogs, these are not. Now, this mechanism is called active transport, and there are several other examples that we'll take a look at in the big chart. I want to define this for you, and the key words here are energy dependent. Active transport means that we are utilizing a metabolic process that's already going on in the body, that is energy dependent, and is able to transport something across the cell membrane and into the cell. So these are potassium analogs, thallium and rubidium, and potassium migrates into the cell by what is called the sodium potassium pump mechanism. It's driven by an enzyme called ATPase, and it pulls potassium into the cell, removes sodium from the cell. And the same thing happens with thallium and rubidium. They're involved in this mechanism. So let's review that again. Active transport means it's utilizing a normally operative metabolic pathway that must be energy dependent. We'll see later that iodine uptake or iodide uptake in the thyroid is also an example. It's energy dependent because it goes from mono to di to tri to tetraiodothyroxine, which is T4. And every one of those steps is energy dependent. Initially, when we give either of those drugs, thallium, rubidium, even potassium, they all go to the heart. We usually see muscle uptake, a little liver, and very little is cleared through the kidneys. As a matter of fact, for thallium, the renal clearance is very, very small, and that's what makes thallium a very good myocardial poison. It just like an overload of potassium could stop the heart, an overload of thallium could do the same thing. And it's like the gift that keeps on giving because it won't clear. It just takes, the biological half-life is 10 days, quite long. Now, if we take a look at these, cestamide and tetraphosmine, they have a curve that's going to look very familiar to you because they have a pretty long biological half-life in the body. This drug, tebaroxime, is, you can ignore it. It's been off the market for 25 years. So here's what the curve looks like. This looks like just like the Ceratec curve we looked at 20 minutes ago. It localizes very rapidly in the heart, and corrected for decay, it's a flat line for hours. So that's why it's okay for us to inject it and have a delayed scan if we want. It's not going anywhere. It might be decaying, but it's not clear. In fact, here's why tabaroxime is not on the market. It went to the heart better than any of the other drugs, but look at this. It cleared out in 25 minutes. If anything went wrong, you had to re-inject the patient with 25 millicuries. Technologists hated that. What if the computer went down? The patient moved so much, you had to start the image over. A power failure. There's so many things that interfered. So that drug came and went very quickly. All right, here's a couple of board questions for you. True, or which one of the following statements is true? Let's go through all of them. All four of these, the potassium analogs, the technetium compounds are all monovalent cations. That is totally false. These two are rubidium and thallium. The other two are not. All of these are trivalent cations, +3. You know that's false. These two are +1, and these two are not even sure what their charges are. Rubidium and thallium are monovalent. These two are not. That is the only correct answer. That is true. And I mentioned MIBG scan. I'll just mention that it's used to map adrenergic receptor sites in the heart. We have done one of these in all the years we've had MIBG, which is 25 years. I know at Indiana University, that's all they use MIBG for most of the time. They don't look for pheochromocytomas. Okay, let's take a mental break for a second. Any questions about the cardiac drugs or anything that we've covered so far today? Anyone? Okay, if not, then cisternogram involves an intrathecal injection into the spinal column. And we're going to be putting the indium DTPA into the pool of liquid in the spinal column, that CSF fluid. We want to watch it migrate up. We're putting this in the pool of liquid. We're imaging that pool of liquid. What do you think the mechanism is?
Compartmental.
Great. And you'll note here 0.5 millicurie. I didn't even need to tell you that because it's an indium compound. We're not looking for tumors. It's always going to be 0.5. And sure, that's compartmental localization. It's an intrathecal injection following a lumbar puncture. Biological half-life in the body is really pretty long, 20 hours. There are no particles. And while the immediate distribution is into CSF, it ultimately migrates up, bathes the brain, and we are able to actually find CSF leakage into the nasopharynx. We can find it by two ways: a painless way, which is scanning, or we can put these cloth strips called pledgets way up into the nasal sinuses, leave them in for X hours. I don't know what X is, take them out and count them. That is an extremely sensitive way to find leakage of CSF. Next is avoiding cystogram. We are taking sulfur colloid. Actually, technetium, anything would work perfectly fine, but we usually use sulfur colloid. Now, we are putting sulfur colloid that's into the urinary bladder. We're filling up the bladder with this liquid. We are imaging this pool of liquid in the bladder. What's the mechanism?
Compartmental.
Again, sure, it's compartmental localization. We filled up the bladder with one of these technetium agents. We only need a millicurie. That's all we need, really, because you're looking at a pool of liquid that is not scattered all over the body. It's sitting right there in front of you. So that's compartmental localization. The particle size of these colloid particles is very small, 0.1 to 2 micrometers. So the immediate localization, of course, is in the bladder and then expelled by the patient for, and while we can determine flow rates, and in particular, is the bladder being completely emptied or not? There are, especially in adult males, probably my age, give or take a few years, many people have trouble emptying their bladder. They go to the restroom and they say, oh, I've emptied it, but in fact, they haven't, and that's why half hour later, they have to go again because they can't tell that their bladder is still half full or partially full. So that's one of the reasons we do it in adults. Okay, here are some potential board questions. How does the internal radiation dose of avoiding cystogram that we do in nuclear medicine with sulfur colloid, how does that compare to fluoroscopy, avoiding cystogram done under fluoro? Which is higher?
Fluoro is higher.
Fluoro, I think we talked about that the other day, but fluoro is much higher. Fluoroscopy is 2,000 milligrams per minute of fluoro time. Our study is going to be 50 to 60 milligrams total, unless somebody can't empty the bladder, but usually they can. While we typically use sulfur colloid, would other tech drugs work? And the answer is sure. Technetium, anything will work. Nothing is going to clear the bladder until it's expelled, so it really doesn't matter. They use sulfur colloid because in theory, it's insoluble, it's little particles, and it can't migrate out of the bladder, but truly it doesn't matter. This is one of my favorite ones here, gastric emptying. We are going to be tracing a radioactive meal through the GI tract and measuring the clearance rate. We might determine the half-time of clearance, and we could use a drug like technetium labeled egg whites, ovalbuminous egg whites, for solid phase emptying, or for liquid phase emptying, we could use indium DTPA. Again, this follows the rule, 0.5 millicurie for both of those. And I wanted to tell you a very interesting story. In 1975, I had a job interview at Temple University in Philadelphia, and they were interested in developing a gastric emptying agent. And I thought that might be pretty nice, but then they talked about developing another agent used for defecography, which involved emptying of fecal contents from the intestines. And that was pretty much the end of my interest in Temple University. I was not the least interested in that. But a young lady that I know took that job, and she became famous for developing the first gastric emptying agent. You might have heard the story. It actually involved live chickens. And this was so successful that they started keeping a flock of chickens in one room in the hospital because everybody and his brother was ordering gastric emptying studies. And the Philadelphia Health Department got wind of the chickens, pun intended, and they said, get rid of the chickens or we're going to shut down the hospital. So short-lived, but very successful. And what it involved was injecting sulfur colloid into the chicken. Chickens have a good wing vein. Inject into the chicken. They waited about 10 minutes, killed the chicken, dissected the liver, cooked it, made pate, and fed radioactive chicken liver to patients. And to this day, there's nothing any better than that because the sulfur colloid is trapped in subcellular components and gastric juice doesn't remove it. So it really is a true tracer of solid phase gastric emptying. But again, impractical to keep chickens around. So today we use the egg whites. Now, this is a study that was reported in 1983 in a journal called Clinical Nuclear Medicine. They took some normal volunteers who did not have gastric issues, and they made some egg whites. And the meal was the following: 3 egg whites, no yolks, and we'll talk about why later. 3 egg whites, 1 cup of water, 1 slice of white bread. And they mixed the sulfur colloid with the egg whites. They cooked it up in a Teflon frying pan. We didn't want any fat there. Put it on that slice of bread and gave it to the patient to eat. And we asked them to eat it, don't choke on it, but eat it as quickly as possible. And then once they have emptied, and once they have finished eating the meal, then we're starting at time 0 right here. And we image continuously out to as far as 90 minutes. Now this big broad band here of white, this is a normal range. Curve A down on the bottom. Now, before I ask you this question, note what we're plotting. What we're looking at visually is we're watching the activity empty from the patient's stomach. That's what we're watching. We're watching it empty, but what we're seeing is what's residual in the stomach. We're not plotting the residual activity in the stomach. We're plotting the percent that is empty. So that's going to go up as a function of time. So take a look at this curve. If I were asking you your board question, here's what it would be. Curve A, down here on the bottom. Does that reflect retarded gastric emptying or rapid gastric emptying?
Retarded?
Good. And in fact, this is an example of what's called gastric paresis, because remember, this scale here is the percent emptied. You can see the percent emptied is very low. It's way below the normal range. Curve B, on the other hand, is higher than the normal range, and that would be very rapid emptying. And curve C, we see this often in patients who have had a gastrectomy. They don't even have a stomach. Their intestines are anastomosed to the bottom of the tube where the food falls down. And so look what happens here. Within 15 minutes, all of it has cleared the stomach area. And this is a disease called dumping syndrome. You might have heard of it before. Very, very easy to diagnose. You don't have to go out to 90 minutes. In 15 minutes, you already know whether it's dumping syndrome or not. So here we have dumping syndrome, too rapid, too slow, and this broad normal range here. Now, please keep in mind, this is a normal range for only that particular meal. 3 egg whites, 1 slice of bread, 1 cup of water. If you were to give whole eggs instead of egg whites with the yolk, whole eggs, all the fat in whole eggs is in the yolk. So fats retard or slow down gastric emptying. So the curve would not be here. It would be a little bit lower. If you gave a marbled steak, potato with sour cream and a salad with creamy garlic dressing, that meal's not going anywhere real fast. That might have a normal range way down here. Now, I came up with what, let me show you one other thing before I give you this question. This is a normal range for solids. Where would the normal range of liquids be? Above or below the normal range for solids?
Would it be
Oh,
It would be above, because liquids empty faster than solids. So now I'm going to switch back and forth. Take a look. This is solids, this is liquids, solids and liquids. Okay. Now, I made up this question, and this has to do with graphical analysis. I don't think it's really a tough question. People typically do get it right. What is the normal range? Now, you see where the normal range is here, this big white area. What is the normal range for the half time of transit? What does the half time of transit mean? 50% emptying, correct? Good. So what would be the numbers for the normal range for the half time of transit? Approximately.
between 30 and 75 minutes,
What was the first number you said?
30 minutes.
70? Not, so take a look. Where does the 50% line cut the normal range? It cuts it right here at about 35 minutes, and it cuts it right here at about 75 minutes. So here I'll show you the lines, 35 to 75 minutes. So that would be the normal range that you would expect that particular meal to empty. I think that's a good graphical analysis question. And if you had a sheet of graph paper where you could draw a straight line from the 50% over, it'd be very easy to determine that. Now, I will tell you that many physicians don't even calculate the half time of transit. They don't do it in my department, but I know other places that do. And to me, it would be a valuable number because we know what the normal range is. So, you know, if the half time of transit is 10 minutes, you know it's way too rapid. And if it's 2 hours, it's way too slow. Okay. Next is GE reflux, gastroesophageal reflux. And the agent of choice, the only thing anybody ever uses is sulfur colloid. And we only give about a half a millicurie. That's all you need. These are really typically done in infants or very small children. And what are we trying to diagnose? Are we trying to diagnose reflux? Believe it or not, the answer is no. Everybody refluxes to some extent. That's a natural thing. What we're trying to determine in these babies is, are they refluxing and aspirating that reflux stomach contents into the lungs? That's what we want to know. So I personally think this is a bad name. I would call it a pulmonary aspiration scan, but nobody does. But keep in mind, we're not trying to diagnose reflux. We're trying to see if that reflux material is ending up in the lungs. Let me back up one more point I want to make. There are two ways to get the sulfur colloid into the stomach. There's a neat way where we can put in an NG tube into the stomach, squirt the sulfur colloid into the stomach, and push in some saline, take the tube out. That's a nice, neat way. The messy way is to give this baby a bottle, but first we take one of those rubber bottle nipples, we put some sulfur colloid into it with a little milk, let the baby suck down the sulfur colloid, then we put the bottle together, the baby drinks the bottle, and that's a messy way of getting sulfur colloid into the stomach. But it is the physiological way. And which is better? The truth is, this messy but physiological way is better because in many people, when that NG tube is pulled out, it causes a reflex spasm that can cause reflux and aspiration in a patient who doesn't even have it. And you can get a false positive study. So the recommended way is to use the, let the baby drink this. Now, if it's an adult, you can probably just have them drink a small amount. Next is an important topic, GI bleeding. The only drug we have today is, of course, autologous labeled red cells, and the typical dose is 25 millicuries. Why do we need so much? The bottom line is, how big is that bleed? Bleeds are usually pretty small. I mean, they could be 5 or 10 milliliters out of 5,000. Sometimes they're small. Sometimes they're not, but often they are. So let's talk briefly about the labeling. We need a very high efficiency labeling. Nothing under 95% is acceptable. We can use an UltraTag kit. That's what we do. And there's a technique that we helped to invent some years ago where you would take the patient's blood and tin it with stannocyan, spin down the tin label red cells, take off the plasma, and label those tinned packed red cells in a centrifuge. Came out with 98 to 100% all the time. But that's truly a pain in the neck compared to using an UltraTag kit, which is very easy. Okay, so we get a great labeling. We image the first perhaps 90 minutes. Let's say we don't find the bleed, and if it's an inpatient, we send him back to his room. We bring him down again at whatever the doc wants, 2, 4, 24 hours, whenever, and just repeat the imaging. Now, here's a scan of a bleed, and already, if you have a good eye, you can see that the bleed is starting right here. You can certainly see activity in the major vessels. Excuse me. The bleed is right here. It's getting darker and darker and more focal. We're out to 45 minutes, and by the time you're out to an hour or more, it's all over the place. So you have to make this diagnosis early, because once it's all over the intestines, you have no idea where the origin is anymore. And so this is a rectosigmoid bleed in a patient. This is a very old scan. It's probably 15 or 20 years old. Okay, great exam questions here. What is the sensitivity in finding a GI bleed in terms of milliliters per minute? Sensitivity means the lowest possible detectable limit. And I'm going to give you some choices here. What's the smallest bleed we can find in milliliters per minute? 10, 5, 1, or 0.5 of a milliliter per minute. Anyone?
Is it 0.5?
It is. Very good. In small animals, we can do better. But in humans, the answer is 0.5. Think of how tiny that is. That is 500 microliters in 60 seconds. We're finding a bleed of about 7 microliters per second. 7 microliters is tiny. That's a very sensitive bleeding agent. How far out can we go on a GI bleeding study after one injection? We can actually go out to 24 hours if we've done a great job of labeling the red cells. Since we can label, I think I just answered this a couple of minutes ago, since we can label with almost 100% efficiency, why do we have to give 25 millicuries? The bleed is often very small. All right, in the last 10 minutes, I've mentioned autologous labeling a couple of times. What does that mean? Autologous labeling. So autologous means we are labeling the patient's own red cells. We're not taking donor cells from the blood bank. We've had to do that on white cell studies where we're looking for an infection and the patient's white cell count for some reason is so low, we can't collect enough white cells. We've done a very few of those over the years. But if somebody is alive and breathing, they got way more than enough red cells to label. So autologous labeling means the patient's own cells are labeled. And here, what about this? What's a mechanism of localization called when we're looking for that GI bleed? All right, want a hint? A GI bleed is a fluid space.
Compartmental.
Sure. We're looking at a very small compartmental space compared to the whole blood pool, but still, this is going to be compartmental localization. Okay, good. Next is hepatobiliary studies. And I wanted to tell you a very interesting story. It's not really very long, that HIDA was invented by accident by a man named Michael Loberg. It's actually a colleague of mine. He was at the University of Maryland in Baltimore at the time. And I happened to have an interview for a job back in that same year, 1975, with them. And they had discovered this drug that they were hoping would be a cardiac imaging agent. And let me show you how he designed the drug. And then we'll come back to that slide. He took the molecule lidocaine and said, you know, lidocaine has cardiac activity. Maybe we could send it to the heart by hooking technetium. But then when he looked at the molecule, there's no place to hook technetium. You need a lot of double bond electron pairs. There were only one pair here. So he took this N-diethyl group off and he replaced it with this N-diacetate group. This is called an IDA group, imino-diacetate. That's where the IDA in HIDA came from. And so when he took this, replaced this with it, here's what he got. And he called this HIDA because he was hoping that this is going to be a heart imino-diacetate. Unlucky for him, it didn't go to the heart at all, but it did go to a different H, the hepatobiliary area. And by accident, looking for a heart agent, he discovered a hepatobiliary agent. And being a smart guy, he called up a colleague at Mallinckrodt Corporation and said, hey, I think I got an agent here that you might be interested in for imaging hepatobiliary scanning. And in fact, they prepared it, marketed it, and sold it for a few years. Today, our choices are Colitech or Hepatolite. This one is methyl bromophenin. Phenin implies that there's a phenyl group or a benzene ring. And this one is diisopropylphenin. They're very similar molecules. And you'll note here that we always give 3 to 8 millicuries. What do we base this on? You all know that normally, excuse me, normally we base our dose on the patient's body mass. Here we don't do that. We get the bilirubin level and we say, gee, this guy has a high bilirubin, we're going to give 8 millicuries. Or bilirubin looks normal, we're going to give 3. There's actually a formula you can use to determine this. Everybody's going to get 3 as a minimum, plus an additional 0.5 for every unit the bilirubin is elevated. For example, it's elevated 10 units. We have 3 plus 0.5 over 2 times 10. This gives us a way to calculate it. In my department, we don't do this. The physician makes a judgment call. Bilirubin is bilirubin is elevated. I'm going to give 8. And that's perfectly okay. Just a scan showing you here that we don't see too much here at 5 minutes, but at 10 minutes we're starting to see a little bit become more and more and more and more focal. This is what Dr. Loberg saw when he first injected it. Never saw the heart at all, but turned out to be a pretty good hepatobiliary agent. I'm going to skip that slide. These are the interventional things that we do with hepatobiliary agents. If we see the liver in the bowel, if we see the bowel, we know that the bile duct is patent, that there is flow down there, but the gallbladder doesn't fill up. Then we can give IV morphine, just a couple of milligrams. What does that do? That constricts the sphincter of Oddi, lets the gallbladder fill up. Conversely, what if the gallbladder fills but won't empty? Then we give a drug called Kinavac, and what that is a portion of the cholecystokinin, the CCK molecule. It's about 1/4 of the molecule, and this is actually, CCK is a polypeptide that has 34 amino acids literally chained on end. And this is 8/34 of the molecule. Just a sketch here. This is the whole CCK molecule. We're just using this end alone to empty the gallbladder. And 5 micrograms is all that it takes. We don't even use that much. Sometimes 2 or 3 is enough. 5 to 10 micrograms would empty the gallbladder of an elephant. It's very powerful. By the way, this is the most expensive drug ever created, because they don't market it based on what it costs them to make. They market it based on how useful is it to the physician. You want to be able to reliably and quickly empty the gallbladder. We got a drug that works. Sure, it's only 5 micrograms. We're going to charge you $40. It turns out that this drug on a per pound basis is over $2.5 billion per pound. Pretty incredible. Now, what's the maximum bilirubin level at which each of these drugs work? And so the reason HIDA went off the market is because of the answer to this question. This is pretty low. If the bilirubin level exceeded 8, HIDA didn't work anymore. And so others were created. There were a couple on the market that went off the market that were better than HIDA, but not as good as these two. Here's your answer. These two, dizofenin and mebrofenin, work up to the low 20s. Once you're over 20, you begin to think, do I really want to do this? But even up to 24, it's been successful. HIDA is actually no longer available. So what's different about the dosing regimen of these hepatobiliary agents compared to all the other tech drugs that we inject? What's different? What do we base it on?
The hepatobiliary.
We base it on the bilirubin level and not the patient's body mass. We don't even take body mass into consideration at all. How many injections of HIDA are performed every year today?
None, right?
That is correcto, none. That drug has been off the market for over 25 years. Everybody still orders a quote unquote a HIDA scan, but nobody can use HIDA. It's just simply not available. Now, there are commonly questions these days about pregnant women, and we're going to talk about several different drugs and pregnant women. And here's the first one. What protocol change would be made for a HIDA scan if the patient is pregnant? Or would we just cancel the study? So I will tell you, we would never cancel the study. So what protocol change would we make? What would we do?
Lower the
Hannah?
dose.
Sorry? Anyone?
Lower the dose.
Exactly. That's exactly what we would do. We would cut the dose in half, double the imaging time, we're not concerned about the patient's radiation dose. We're concerned about the fetal radiation dose. That's what we're trying to protect. So we would take our dose, cut it in half, double the imaging time. I would imagine we would double the discomfort where that pregnant lady has to lie still for twice as long. But we have cut the fetal radiation dose in half. We would almost never, ever cancel a study on a pregnant patient. The risk to benefit ratio will always be in the patient's favor. Acute myocardial infarction, we've already discussed this. I'm not going to spend much time on it. They're not likely to ask you about it, but the agent of choice is pyrophosphate. We typically give 25 millicuries because infarct is small. And I mentioned earlier, chemisorption. And here's what's happening. And then I'm going to show you a sketch. I just made it last night. You're the first class to ever see it. When a myocardial cell dies and becomes necrotic, the cell wall ruptures and there's an influx of calcium ion into the cell. Now keep in mind, there's still some minimal blood flow. So calcium is going to bind to circulating phosphate, and look what happens. Calcium goes through the break in the cell wall. It interacts with phosphate and forms tricalcium phosphate crystals. That's called hydroxyapatite. Here's just a little area where there are gazillions of little crystals of it. And this shows up as a hot spot. The rest of the heart will show up as a cold spot because pyrophosphate does not localize normally in cardiac tissue at all. And so what happens immediately, not immediately, but over the first 24 hours is the formation of hydroxyapatite crystals. Then we come along 24 to 72 hours later, and then we inject the pyrophosphate. We never inject before 24 hours ever. It can take that long for necrosis to take place, for this reaction to take place. And so we can image out to 24 to 72 hours. Now this says, what is the optimal imaging time? And that is the correct answer. 1 to 3 days, 24 to 72. We can often go out to 5 or 6 days. And after that, this mechanism simply doesn't work anymore, and you get false negative studies. The bottom line here, however, is you're not going to ever do one of these, highly unlikely. This, I think I've asked you before, on the rare occasion we would do one of these, would all of these bone agents work? The answer is yes. Can technetium pyrophosphate differentiate between infarct and scar tissue? Yes. Infarct will be a hot spot. Scar tissue will be a cold spot. Is pyrophosphate taken up by ischemic areas? We already had that. The answer is no. And unless you know the history of infarct imaging, you wouldn't know the answer to this, but true or false, acute MIs can also be detected using glucoheptanate, technetium tetracycline. I've actually made that before, an indium-labeled anti-myosin antibody. The answer to all of those is true. And in fact, indium-labeled anti-myosin antibody was called Myosint. It was on the market for a couple of years. And the reason it went off the market is cardiologists wouldn't order the scan. They just felt like they didn't need it. Kidneys are next. And kidneys are often the focus of exam questions. So these are the 3 drugs that are available today. Glucoheptanate used to be, but it's off the market. But we have DTPA, DMSA, MAG3. Now, you should know what those acronyms stand for. This, of course, is diethylene, triamine, pentaacetic acid. It's similar molecular formula to EDTA. EDTA is ethylene, diamine, tetra. This is diethylene, triamine, pentaacetic acid. They're like chemical first cousins. Probably give about 10 millicuries. This is dimercapto. A mercapto group is an SH group. It's also called a thiol group. Dimercaptosuccinic acid. And this is a renal morphological agent. And MAG3, that's mercaptoacetyl triglycine. And that is a tubular secretory agent. Okay? So DTPA is filtered, MAG3 is secreted, and DMSA binds to the tubules. So let's take a look a couple of important things here. MAG3 is the only one that is active transport. That's the mechanism for this one, for tubular secretory function, because this is a metabolic process going on in the body already, and it's energy dependent. The others are not energy dependent. They are passive processes. So MAG3 is for tubular secretory function, and the ratio of secretion to filtration is about 80 to 20. We'll see that in the next question and the chart that goes with it. And, we often image out to 30 minutes, often break it up into 3-minute frames of time. We can draw renogram curves and so on. Some part of this might be a good exam question. This is the percent of filtration, percent secretion, percent binding. And this is really pretty easy if you remember just a couple of things. Number one, DTPA is quantitatively filtered. So this is going to be 100, 0, and 0. Remember, these are approximate numbers. It might be 90, 96, 0, and something here, but predominantly filtered. MAG3, I already told you 80, 20. And so let's take a look at all the answers. Predominantly filtered. MAG3 is 80, 20. And yes, you're going to see other numbers in books. I've seen 85, 15. I've seen 80 to 90 and 10 to 20. But these are just good average values, around 80 to 20. You'll note these two don't bind to the tubules at all. They clear pretty rapidly. And the kidney dose is going to be pretty low, renal dose. But look at DMSA. 80% binds to the tubules and never lets go. It's a binding agent. And so biological half-life is going to be long, and therefore the T effective is going to equal T physical, which is equal to 6 hours. So it's going to be dosing the kidneys consistently for many hours. And it also has a filtration component. I guess that's a good part because 20% of it clears rapidly. Okay, a couple more good board questions. Back to the pregnant lady again. Now she needs a renal scan. Which one of those 4 drugs poses the greatest fetal risk?
DMSA.
100% DMSA. It sits in the kidneys and irradiates the fetus, and it's not going anywhere. It's just sitting there. These two, DTPA, MAG3, are going to clear pretty quickly. Now, that has to do with the fetal dose in a pregnant lady. This is the same question, but it involves all patients, pregnant or not, all patients, and we're asking about the kidney dose. So which one of those compounds will confer the highest radiation dose to the patient's kidney?
Would that still be DMSA?
Sure, DMSA, for the same reason. Long biological half-life compared to the others. And so when we use DMSA, the only consideration, we're not worried about the radiation dose for a typical healthy patient. We're not worried at all. It's going to be higher than the other two, but it's still well within diagnostic limits. It's not anything to be concerned about. Here it's of concern because we're talking about fetal dose. Okay, considering these 3 compounds, which of those 3 molecules has a structure similar to EDTA?
Is it DTPA?
Sure. Remember, diethylene triamine penta, this is ethylene diamine tetra, and the A is acetic acid for both of those. Which one of these drugs is cleared predominantly by tubular secretory function?
MAG3.
That's going to be, yes, tubular secretory function. That will be MAG3 for sure. Okay, any renal questions from anyone? Okay, good. Let's take a look at liver. The only drug we have today is sulfur colloid, and the typical injected dose is 5 to 10. We use 8 millicuries. We have never used more than that in over 40 years. There's no reason to. You're okay with 5 millicuries, really. I mean, 90% of it is in the liver and the spleen. So you don't really need a lot. It doesn't go to other places, a little to the bone marrow. Now, here's a mechanism. They ask about this periodically on exams. The mechanism for this colloid is that Kupffer cells in the RES. That's the reticular endothelial system, liver and spleen. Kupffer cells in the RES will phagocytize these colloid particles following an intravenous injection. Now, the chemical nature of the colloid is irrelevant. The only thing that matters is the particle size. We're going to take a look at that in a moment. So there are other colloids that have been used. There was a microcolloid made from MAA, I believe it was. But anyway, we're going to use sulfur colloid. The mechanism, phagocytosis. Now, the average capillary is around 7 or 8 micrometers in diameter. But look how small sulfur colloid is. 0.1 to 2 micrometers. Very tiny. So we're not going to get capillary blockade. We would never expect to see pulmonary uptake following a sulfur colloid injection. If we do, there's something else wrong, probably more with the technologists than with the patient. We're going to talk about that in a couple of minutes. So this is a liver scan, a normal looking liver scan. And in about 5 minutes, I'm going to show you an abnormal looking one. What's going on here in this first view? This is an anterior view, and I see 4 white squares here. Is that square?
Is it a
Yeah, I
marker?
was going to ask you if that's square liver disease, but you of course know that it's not. That's a marker, and it's used to size the liver. The liver might be, the square might be of lead, might be say 5 centimeters, and the square of canvas in between it might be 5 centimeters. And so we could say, okay, this liver is 5, 10, 15, 20, 25, 30, 35, 40 centimeters across, which is used to size the liver. And you can see all the different views. RAO, right lateral, posterior, left lateral, a lot of views here. A normal liver scan is well perfused everywhere in the liver. And out here, you can see the splenic activity way out at the right-hand end. Now, let's take a closer look at particle size. Colloids are defined as suspensions in a fluid medium, not liquid, but fluid medium. For example, diesel exhaust from a big 18-wheeler truck is full of colloidal particles. Cigarette smoke is full of colloidal particles. That's one of the reasons it's dangerous to lungs. Those particles get in there and can't clear out. So any suspension between 0.05 and 4 micrometers is called colloidal. A subset of that is sulfur colloid. That's between 0.1 and 2. So it's certainly well within 0.05 to 4 micrometers. MAA would fall way out to the right, which is 10 to 90 micrometers. So MAA, the particles are much, much larger. They're still small, but much, much larger than this. Okay, a couple of clearance questions. What's the half-life of clearance from the blood pool? Now, let's say you don't know the answer to that question, but you do know that when we inject sulfur colloid, we never wait over 10 minutes. That means that clearance pretty much has to be done within 10 minutes. So which 3 of those could you throw away? You know they're wrong.
30.
Yep. And which 3 of them can we throw away?
1 minute and 2.5 minutes.
No, I don't think so. Think about this. Let's say that it clears with a half time of 10 minutes, and you've waited 10 minutes to do your liver scan. How much of the activity is still in the blood pool? Half of it. Here, if you wait 30 minutes, probably 75 or 80%. Even if the half time of clearance was 5 minutes and you waited 10 minutes, you've gone through 2 half-lives. 1 half squared is 1/4. You still have 25% remaining in the blood pool. You don't want to do a liver scan when there's blood activity all over the place. So these 3 could be thrown away. So you can at least say process of elimination. It cannot be C, D, or E. And here you'd be taking an educated guess, but at least you got a half of a chance to get it right. The correct answer is 2.5 minutes. It's right in the package insert. So, okay, is that clear why 1 and 2 would not be the correct answer. I'm sorry, why 5, 10, and 30 could not be the correct answer? Because it's still leaving so much in the blood pool. How about this? What is the approximate biological half-life of sulfur colloid in the liver? Is it 0 hours or 1, 6 to 8, 24, or is it there forever?
Definite, isn't it?
Yes, it is. Humans cannot clear sulfur colloid from their liver. And so it's there with a biological half-life that we say is infinitely long. And in the case where the biological half-life is infinitely long, that tells us that the T effective is going to equal 6 hours because that's the T physical. So the liver, from our standpoint, is simply going to decay with a 6-hour half-life. But keep in mind, what does technetium-99m sulfur colloid decay to? It decays to the ground state. And in 60 hours or 10 half-lives, all the sulfur colloid left in the liver is now Tech-99 colloid with a half-life of 220,000 years. We're not even worried about that. No human could live long enough for there to be enough decays in a lifetime to be significant. So yes, it's infinitely long. Now I've asked this question before to classes and I say, what's the biological half-life of technetium 99 colloid? And they say it's 0. It's not 0. Nothing has a biological half-life of 0. It could be very short, but not 0. And it certainly could be infinitely long. Now this I've already mentioned. What are the numbers? What's the percent uptake in liver, spleen, and marrow, respectively?
Is it 85, 10, and 5?
Perfect. That's right. Now, most books don't give you these numbers. They tell you this is 80 to 90, this is 5 to 10, this is 5 to 10. These are simply good average numbers, and those are the numbers they're looking for in an exam. But you also might see 80 to 90, possibly. Now, remember earlier when we were talking about bone agents, we had a scan with a name. You'll recall what that was. We said that there was a super scan. So take a look at this. This is a scan with a liver that looks like Swiss cheese. This, in fact, is a patient on the transplant list because there's very little functioning liver tissue that's even remaining. But what you also note is that the splenic activity is significantly hotter than the liver. So this scan has a name. What is it called? Anybody know?
Colloid shift.
Good. The activity is shifted from the liver to the spleen, and here it is, colloid shift. Now, go back up to the top right image here. What do you see in that top right-hand image?
See the marker.
Good. Still, you can still see the marker here. It almost, at first glance, you might not even notice it, but certainly there are the 4 white squares where there's lead and nothing is penetrating, and the camera finds nothing in the squares. Good. So that's the marker. Now, I have seen this happen in a lab before, not my lab, because we made sure our technologists knew not to do the wrong thing here. Let's say at 7 a.m. this morning, you made sulfur colloid. You injected it 5 minutes later, you did a liver scan, got an excellent liver scan. Now, the chief tech adds on a liver scan 6 hours later. 1 half-life of technetium has gone by. That's pretty irrelevant for this question. But look what happened. The technologist took that vial of sulfur colloid, gently inverted it, very slowly and carefully drew a second dose and injected it. And he got a liver scan, but he also got a scan that shows multiple hot spots in the lungs. Do you think that's pathology, or did the technologist do something wrong?
Is it when it inverted the vial, it messed up the colloids? I can't remember the exact.
Yeah, you're sort of on the right track a little bit. First of all, it's not pathology. Here's what happens with sulfur colloid. Colloids as a function of time, will settle. Remember, they're particles. They will settle to the bottom of the vial, and they will clump together and make macro aggregates the size of MAA, and they will end up as hot spots in the lungs. So there are two ways to prevent this. The way I would prevent it is take a 10 cc syringe, hook to it a tiny needle, like a 25 gauge needle, and I would pull that sulfur colloid back and forth rapidly 2 or 3 times through that needle. The turbulence in the bore of that needle will disrupt those clumps and take you right back to what the prep looked like at time 0. If you don't want to be bothered with the syringe, you can also take that vial of sulfur colloid and just shake it very vigorously for maybe 10 or 20 seconds. I don't recommend shaking any other drug because it can really ruin them, especially soluble drugs. But this is insoluble particles. And it's okay to shake it. You have to do one of the two things, either shake it or pull it back and forth through a small needle, and then you will not get those hot spots in the lungs. So if sulfur colloid has aged even more than 30 minutes and certainly more than an hour, you've got to shake it up. Otherwise, you're going to get hot spots in the lungs. And then the doctor reading the film doesn't know if that's pathology or the technologist didn't do the right thing. Now, what can sulfur colloid be used for? Which of these procedures? Preparation of egg whites? Yes or no?
Yes.
Yes. A gastroesophageal reflex study? Yes.
Yes.
A lung scan?
No.
No. No. So the correct answer, of course, is D, A, and B only. Here's another example of always read every possible answer. You never know if there's a combination choice like A and B only. Next is pulmonary perfusion. There's a lot of really important but very technical information here. And this is going to help you a lot, might clarify some questions you might have. The only drug that we have today is MAA. That stands for macro. That implies large particle. It's not large to the naked eye, but it's large compared to sulfur colloid, for example. And why do we give so little? We only give 3 millicuries. Remember, we inject and we start imaging right away. We have 0 wait time. Over 95% of it goes to the lungs, and the lungs are nice and compact. So almost all the activity is there. You don't need more than 2 or 3 millicuries. So mechanism is called capillary blockade. In one book, I saw blockage, but mostly it's capillary blockade. A lot of big words in this paragraph. We have an intravenous injection. We have a radiolabel with technetium product. It's a precipitated, it's insoluble, precipitated albumin made from human serum albumin. And the little micro emboli that are made, the mini clots made in the lungs, are biodegradable with a half-life of about, 5, 6, 7 hours. And they're macro aggregates. So we're going to form micro-sized blood clots in 350,000 capillaries. Now, one thing you never do is tell that to the patient. You told the patient, I'm going to make 350,000 micro emboli in your lungs, but don't worry, it's not a problem. That will frighten the patient terribly. So you don't ever tell them that, but it's a technical thing to note. We're making microemboli. Now, the diameter of a capillary is 7 micrometers. We want to blockade or occlude those capillaries. So MAA has to be bigger than 7 or 8 micrometers. So here's your board question. And the answer to this has not changed in 45 years. What are the legal particle size requirements? Anybody know?
10 to 90 micrometers.
Good. So 90% of all particles have to be 10 to 90 and 0 particles greater than 150. Now, this is done by a microscopic exam. I could teach you how to do it in 2 minutes. There's nothing to it. You have what looks like a very thick microscope slide that has a grid on it marked off in micrometers. You simply take a look and say, oh, this particle goes from 30 to 70. That means it's 40 micrometers in size. Anybody could do it. It's very easy to do. But these are the legal requirements. 90% 10 to 90 and 0 greater than 150. So remember here, we said that capillaries are 7 or 8, and that's why it has to be bigger than 10. Why is there a limit of 90 on the upper end? We don't, you have people who have pulmonary circulation that's compromised. The bigger the particles, the bigger the blood vessels you're likely to occlude. We don't want to get the patient in trouble. And so every vial of every batch ever made has to follow this rule. And here's your next question. Who's responsible for doing this microscopic exam? Manufacturer, the hot lab tech, or there's no requirement?
Manufacturer.
Sure. Manufacturer has to certify that every vial of every lot will meet those specifications. We never have to do it. I've had a couple of interested techs and say, could you show me how? And I got out a microscope and I showed them. There's not much to it, but we don't have to do it. We want to do it, we could, but we don't have to. Responsibility of the manufacturer. Now, this is a question to put 2 stars by. Very important question and important answers. And they're numbers that you as technologists will need to know. There are 4 categories of patients where we do pulmonary perfusion scans. On a rare occasion, I would say maybe once a year, twice a year, we'll do a neonatal lung scan. And I don't know what the indication's for, but we do them. You have to make a special prep for them. You cannot use a regular adult prep. Children ages 1 through 18, we have to scale up the dose based on their body mass, but within the limits of age 1 to 18. We have patients who have pulmonary hypertension. That implies vasoconstriction, and the more particles you give, the faster you're going to get them in trouble. So there's an upper limit of how many particles for pulmonary hypertension. And then normal patients. If any of you out in the audience, and including myself, if we're all pretty healthy right now, we are much less concerned about how many particles. So here are the numbers. Neonatal lung scan, we're going to administer 50,000 particles across the 2 lungs. That means each lung is getting about 25,000 particles. We can maybe go up to 60,000. I wouldn't go more than that. We're very careful. We hold it to 50. If it's a child, then we're going to go from year 1, we're going to assume it's about 100,000 particles, because a neonate might weigh 2 or 3 kilograms, but a 1-year-old child probably weighs 6 or 8 or 10 kilograms. So we're going to scale up from 100,000 particles to 350,000 particles in children up to age 18. Now, what's the best way to scale up? By age or body mass? And this is, of course, the right answer. Age is a terrible way to do it because children have very disparate weights for the same age. I have a grandson now who is very small compared to his twin brother, and they're obviously the same age. I wouldn't scale them up by age, even though they're twins. I'd scale them up by body mass. Patients with hypertension, pulmonary hypertension, we go for 150,000 particles. You have to know how to make that vial. You cannot take a regular vial that you made for an adult and draw a dose of 150,000 particles, because the radioactivity will be wrong. If you chose the right radioactivity, you'd end up with 400,000 particles. You have to know how to make this up, special way. Finally, for any of us, the package insert calls for 200,000 to 700,000 in patients who are not known to have pulmonary hypertension. So here's what's happening. We are microembolizing those hundreds of thousands. Think about this, 700,000. We have almost 1 million capillaries occluded by particles and occluded for several hours. So are we worried about that or not? And the answer to this question will tell you why we're not worried. What fraction of all capillaries is occluded by the typical injection of technetium MAA with one of these numbers here, up to 700,000? So let's take a look. There are billions of capillaries. We are just not worried about 700,000 or even 1 million capillaries. In fact, only 1 in 1,000, 0.1% is included in capillaries. Even if you included precapillary arterioles in the count, it's 1 in 100,000 that are included. And so we're not worried about this because this says 0.1% or 99.9% of the capillaries are patent. They're wide open. So the fraction included is tiny. So the margin of safety is simply enormous. We're just never worried about it in a normal patient. We will certainly worry about it in this guy with pulmonary hypertension. Any questions about any of those numbers of particles from anyone? Okay, good. Now, I'm going to ask you a question that involves some pretty low-level mathematics and an understanding of half-life, which I know you all have. Let's say you made a vial of MAA at 7 o'clock this morning. You drew a 3 millicurie dose, and it contains 300,000 particles in a reasonable volume of 0.5 milliliter. Okay, that's all perfect. 300,000 particles, and it's a normal patient. Okay, now we've added on another patient at 1 p.m. So one half-life has gone by. We're still going to draw a 3 millicurie dose because that's our standard dose. So how many particles would be in the second dose? Remember now, we have decay of 6 hours. We're still choosing a 3 millicurie dose. How many particles would be in the second dose?
Double, so 600.
Perfect. That's great math. What happened? Well, you're still getting 3 millicuries. We have to double the volume because the activity got cut in half. And so when you double the volume, you double the number of particles you draw. And here's the math. We got 3 millicuries, but here we drew a 0.5 milliliter with this many particles. For the second one, we had to draw 1 milliliter to get 3 millicuries. And that simply doubled the number of particles. Great. Let's go back. This is probably the last time, but we're going to talk about the pregnant lady. She needs a lung scan with technetium MAA. We already talked about cutting her dose in half, but which one of the following factors is the most important for fetal radiation safety?
Activity?
Good. The activity? Perfect. We don't care about the volume. We don't care about the number of particles, and we don't care about the size of the particles. All of this is an issue for the mom, not for the baby. The only thing we care about is the activity, because the more activity in the mom, the more the fetal dose will be. So these particles never get past the mom's lungs. They'll never get to the fetus. So we don't care about the number, the size, or even the volume of the activity injected. Very good. Activity. In the case of a nursing mother, how long does she have to wait before she can resume nursing her child for technetium MAA? Now, this answer will be the same for all technetium radiopharmaceuticals, even the ones that clear fast like DTPA. It's going to be the same answer for all of them. How long does she wait?
Is it a day?
Good. For all tech drugs, we're going to wait 24 hours before she can resume nursing her baby. Now, what if the mom was nursing a baby, but she underwent therapy with I-131 because she was hyperthyroid? She's got 10 millicuries of I-131 on board. What's the rule for I-131? I'll give you some choices. 1 week, 1 month, 3 months, or complete cessation of nursing for this child.
Cessation.
Cessation of the
Complete cessation. The NRC regulations are very clear for I-131, sodium iodide, maybe not other drugs, but sodium iodide. If a mom is nursing, she cannot, some of them use a pump and put that milk in the freezer. You can't do that. Cannot do that. And you cannot nurse that child ever, not that child ever again, maybe 6 months down the road, but just to stop. What's the approximate biological half-life of MAA in the capillaries in the lungs? Correct answer is about, choice B, about 6 to 8 hours. That's another reason why we're not too worried about those particles occluding capillaries in the lungs. They're going to clear out pretty rapidly. Pulmonary ventilation. I think we're going to, let's see, we'll get through this and we might be able to cover one more topic before we stop for the day. And then we'll finish up this big chart next week and cover some other radiopharmacy related topics. So we have pulmonary ventilation. We have two choices. We have xenon gas, which is what we use. And we can also use DTPA aerosols. Now, the advantage of the DTPA aerosol is convenience. You can keep a vial of DTPA on the shelf. You get an emergency study, you add some technetium to it, you make it up, you put it in the nebulizer, you blow into the patient's lungs. It's convenient and it's not decaying. That vial is sitting on the shelf waiting for you. With xenon, however, it's radioactive. And so if you get it on Monday, by the time Friday rolls around, you've gone through almost a half-life, you got nothing left. So, we always have a vial of xenon. We either use it or lose it, but we always have one. We're a teaching hospital. We don't want to have to wake up the pharmacist at 4 o'clock in the morning and have him drive to the pharmacy, open the pharmacy, check out a dose, put it and give it to a driver and drive it to us. We can't wait that long. So this is a matter of convenience. That's the plus side. This has a different advantage though. Xenon truly is a gas and a ventilation agent. The aerosol is tiny little micron-sized particles that are blown into the lungs. And it does a very good job in the central airways of the lungs, but it doesn't do such a good job out at the periphery of the lungs. So it's not quite as good an agent as xenon. Nevertheless, many people use it. And for xenon gas, we often give 30 millicuries because we want to look at washout, and washout takes place over a couple of minutes, several minutes maybe, and we need that high activity to have enough residual activity to look at washout. What's the mechanism of localization for xenon gas? Remember, it is a fluid. It's a liquid or a fluid, but it's a fluid. We're putting into the lungs. It's a fluid space. So what's the mechanism?
Compartmental.
Again, compartmental. So you can see a lot of our drugs are compartmental because they're involving that fluid space, and we're imaging that fluid space. So xenon, of course, is a true gas. It has no particles at all, truly just a gas. Now, there are two mechanisms of localization here. The first one is during the breath holding phase. The patient inhales and holds the breath for as long as he can. That is the compartmental localization. But there's another mechanism going on here, and that is that while that xenon gas is in the lungs during the breath holding phase, some of it is passively diffusing through through membranes in the lungs because of the lipophilic nature. So it can either be called passive diffusion or, the bottom of that paragraph, simple diffusion. I don't know why there are two names for it, but there are. So that is the second mechanism that's involved. Now, what happens when the patient exhales xenon gas? Remember, he's got a mask over his face and a tube going out. What happens to the xenon? Is it ducted through that flexible tube to the outside air? That's not a bad thing to do, but nobody ever does that. So that's not what we would do. Is it ducted through a flexible tube and collected in an activated charcoal trap where it decays?
Yeah.
Yes. And that activated charcoal trap, it's a really large cylinder of activated charcoal, and it's in a device called a xenon trap. So once you've used it once, that trap now is radioactive with a half-life of 5.3 days. So that trap has to have a lot of shielding in it, and it does, of course. It's got a lot of lead in it. So you don't want to try to pick up one of those traps, it's just too heavy, but they certainly roll easily. Removed by the room ventilation system? No. That's only in the rare case where somebody might pull off a mask and blow the xenon in the room. and then we're going to rely on the ventilation system. But otherwise, no. It decays so rapidly, 5.3 days is not rapid. So that can't be right. Let's cover one more short topic, which is lymphoma therapy, and then we'll stop for the day. It'll take less than 5 minutes. The drug we have today is yttrium 90 Zevalin. We used to also inject indium 111 Zevalin just to take a look for abnormal or anomalous uptake to make sure it went to the right place. We don't even do this anymore, and I really need to delete that. We inject yttrium 90 Zevalin. The limit, no matter how large the patient is 32 millicuries. And the reason is that if the yttrium 90 breaks off of the Zevalin, it's going to go straight to the bone marrow. It forms a colloid in the body, and it will dose the bone marrow, and we don't want that to happen. And so a 32 millicurie upper limit is set. It's enough to cure the patient or at least create a remission, but not enough to seriously harm the bone marrow. There was another drug, iodine 131 Bexar. It's gone. It's been gone for years. Everybody liked to use Zevalin because you could inject it, stand right next to the patient, and get nothing. Yttrium 90 is a pure beta minus emitter, no gammas. But look at I-131. Who wants to be in the room with it? It's got 19 gammas and 6 betas. Nobody wants to be around it. It's the worst drug, the worst isotope that we ever have to deal with from a radiation safety standpoint. Now, here's the mechanism for that. It is called an antigen-antibody reaction. The antibody is what we're injecting. The antigen is what's called the CD20 receptor on the lymphoma. So we radiolabel the antibody. Here it is, yttrium 90 Zevalin. That's the antibody against Hodgkin's lymphoma. And when we inject that, it localizes preferentially in the tumor and delivers a tumoricidal dose to the patient. There's always liver uptake to deal with. And what has made that a much improved situation is that when they first started using antibodies, probably 30, 35 years ago, the success rate was very poor because most of it went to the liver. And then someone got the very smart idea of fractionating that antibody, using a small fragment of it instead of molecular weight 300,000, maybe using a fragment with 75,000 molecular weight, but which has immunogenic activity. And what that did was that it minimized the liver uptake and it optimized the amount taken up in the tumor. And that's why some of these drugs have been so successful. And so we get a little bit in the tumor, and most of the excretion is either through the colon or through the kidneys. I redid this whole question last night, and so the one in your lecture notes will be incorrect because it has some Bexar issues in there that we don't need to deal with. So which two are true? Let's just say true or false for each of them. Zevalin is a radiolabeled monoclonal antibody to lymphoma. That is true. Zevalin is targeted to the CD19 receptors on B-cell lymphoma. That is false. It's actually the CD20 receptor. There are CD19 receptors, but maybe not on B-cell lymphoma. So that is false. The cure rate for Zevalin is 90%. That is totally false. The cure rate is around 30%, and the remission rate, either partial or total, is about 80%. The cure rate is nowhere near 90. Pure Zevalin is a pure beta emitter. That is true. So the first one and the last one are true, and the middle two are false. So A and D are true, and B and C are false. Okay, and it's exactly 2 minutes after 11. We're going to stop right here. And let me stop the screen sharing for a moment so I'll be able to see your beautiful faces again. Okay, and now's the time to ask a question. Feel free to unmute yourself. Anything we have covered in any lecture. Anyone? No? Okay, great. Then I will see you again at 9 o'clock next Tuesday morning. And we're going to start with lympho and finish the big chart and cover some more radiopharmacy. The lecture after next week is one of the most high yield lectures that there is. And that's going to cover the current NRC regulations and hot lab quality control. We're going to great depth, especially into NRC regulations, because there are always questions on the exam, always. Okay, if you have no questions, then I wish you a good day and a good week, and I'll see you next Tuesday morning.
Thank you.
Thank you.
Thank you.